Hi everyone, myself Dr. Sumalatha, working in the Department of Oral Medicine and Radiology, Babu Ganaridas College of Dental Sciences, BBD University, Lucknow. Today we are going to discuss about hepatitis. So, hepatitis is an inflammation of the liver caused by viruses, heavy consumption of alcohol, toxins, wrong medications, autoimmune diseases among other causes. 80% of viral hepatitis infections are caused by hepatitis A virus, B virus, hepatitis C virus, hepatitis D virus, or hepatitis E virus. Hepatitis type B, D, and C virus are of particular concern for oral healthcare professionals because of their parental mode of transmission and they have the ability to establish chronic infection. Whereas hepatitis A virus and E virus, they predominantly spread through internal routes and they do not incur any chronic disease. Coming to the epidemiology of hepatitis, the hepatitis B, D and C virus, they all exhibit significant genetic diversity as evidenced by traceable geographic distribution. For hepatitis B virus, there are 8 genotypes and numerous subgenotypes and hepatitis B surface antigen subtypes. The predominant genotypes observed in the United States are hepatitis A, D and G. Hepatitis D virus is a defective virus which always requires the presence of hepatitis B virus to establish the infection. And this hepatitis D virus has 3 distinct genotypes. The predominant genotype of hepatitis D virus observed in the United States is type 1. For hepatitis C virus, there are 6 types and numerous subtypes. The predominant hepatitis C virus genotype present in the United States is subtype 1. All these viruses spread via contact with contaminated blood. The vertical transmission from an infected mother to the child accounts for most cases of hepatitis B virus infection worldwide. For children who are born of infected mothers who are hepatitis B antigen negative, the risk will be only 10 to 40%. Whereas the children born of mothers who are hepatitis B antigen positive, the risk will be 70 to 90%. The transmission can occur between child to child also. Transmission via the above mentioned routes has been reduced dramatically in the industrialized world in large part due to the implementation of aggressive vaccination and screening programs. The other major risk factor for hepatitis B infection includes multiple sex partners, sex with HBV infected person and intravenous drug use. The neonates whose immune system is immature have 90% of chances of developing chronic hepatitis B infection while compared to the 30% chance for children aged between 1 to 5 years and 5% chance for adults. The predominant risk factor for hepatitis D infection are intravenous drug use, sex with an infected partner, and exposure to blood products prior to 1992. The infection may occur simultaneously with hepatitis B infection, which is termed as co-infection, or it can also occur as a new infection affecting a patient with chronic hepatitis B infection. This is termed as superinfection. The chronicity is more likely to occur as a consequence of superinfection. The hepatitis C virus, the predominant route of transmission is intravenous drug use, which account for 50% of cases. The mother-to-child transmission risk is estimated to be about 4 to 7%, which will increase to 4 to 5 times if the mother is also co-infected with HIV infection. The other risk factor for hepatitis C virus infection include exposure to blood products, which usually occurs prior to 1992, undergoing unsanitary medical procedure, having sex with an infected partner, and household contact. The worldwide disease burden of these viral hepatitis is very significant and there is an extensive geographical variation. Over 2 billion people have been infected with hepatitis B virus, with an estimated 350 billion manifesting chronic infection. The chronic infection rates are highest in sub-Saharan Africa, most of the Asia and Pacific, and it is lowest in Western Europe and North America. For hepatitis D and C virus, the worldwide estimate for chronic infection is 10 million and 170 million people respectively. The most cases of hepatitis D infection affect those living in the Eastern Mediterranean. The prevalence rate for hepatitis C virus is highest in Africa and Eastern Mediterranean, whereas it is lowest in Europe. Coming to the diagnostic aspect of hepatitis, there are mainly two types of hepatitis, acute and chronic. These patients may have no symptoms or there may be mild symptoms that they can be easily overlooked. For example, fatigue, nausea, fever, abdominal pain and loss of appetite. As a consequence, the hepatitis always discovered during routine laboratory screen as a part of physical examination or during voluntary blood donation. The more characteristic signs and symptoms of jaundice are urticaria, dark colored urine, light colored stools and an enlarged or tender liver that always signals the presence of more extensive liver damage. The other condition which we can consider in the differential diagnosis of viral hepatitis includes alcohol abuse, fatty liver, autoimmune hepatitis, primary biliary cirrhosis, hemochromatosis, Wilson's disease and alpha-1 antitrypsin deficiency. The laboratory test is very essential for establishing the diagnosis of viral hepatitis as well as to monitor the disease progression and to assess the results of therapeutic interventions. The basic liver function test includes alanine aminotransferase, alkaline phosphatase, asparated aminotransferase, albumin and total protein. Although useful, the liver function test should always correlated with specific serological tests to establish the etiology. The specific tests available for hepatitis B virus includes hepatitis B surface antigen, hepatitis B virus surface antibody, hepatitis B E antigen and hepatitis B virus E antibody and hepatitis B virus core antibody. So these four are the specific tests for diagnosing hepatitis B virus. For hepatitis D virus, the specific test includes hepatitis D virus antigen and hepatitis D virus antibody. Whereas for hepatitis C virus, the only routinely ordered test is hepatitis C antibody test. Coming to the pathogenesis of these viral hepatitis, the pathogenic mechanism of hepatitis B, D and C, they are only partially understood. There are numerous factors like route of transmission, viral subtype and the patient's age, immunocompetency and health. These all factors will influence the pathogenesis of hepatitis. Although these viruses are hepatotropic, but they do not appear directly to cytoplasm. And the severity of the hepatocyte injury will always reflect the intensity of the host cellular immune response. The patients who develop vigorous cytotoxic T cell response to infection, they are always more likely to manifest severe, at times very fulminating liver injury. But there are low risk in developing chronic infection. But the patient who generate less vigorous cytotoxic T cell response to the infection, they manifest very little acute liver injury but at a greater risk for developing chronic infection. So this is a schematic diagram showing the pathogenesis of hepatitis A virus. It enters the body through the mouth and it is multiplies in the oropharynx and intestinal epithelial cells, then enters into the bloodstream and then targets the liver where it can replicate. The chronic infection is a dynamic process for which the outcome varies from one patient to other. Some patients manifest no symptoms throughout their lives, while others manifest occasional flares of clinical illness, and still others experience unrelenting progressive clinical illness. The two main concerns related to chronic viral hepatitis are increased risk for developing cirrhosis and hepatocellular carcinoma. For patients with chronic hepatitis B virus, the risk of developing cirrhosis or hepatocellular carcinoma is only 50 to 40%. The contributing factors for this is male sex, infection at early age, heavy alcohol consumption, co-infection with other hepatotropic virus or HIV virus, immunosuppression and high hepatitis B virus viral loads. For chronic hepatitis C infection, 20% of patients develop cirrhosis over a period of 20 to 30 years. Once the cirrhosis occurs, only 1 to 4% of patients with chronic hepatitis C virus can develop hepatocellular carcinoma each year. For chronic hepatitis D virus, the progression to cirrhosis typically occurs within 5 to 10 years and affects 60 to 70% of the patients. So, till here we discussed about the pathogenesis, epidemiology and modes of transmission of hepatitis. So, the next class will discuss about the medical management and the oral health consideration of treating patients with viral hepatitis. Thank you all for your patience listening. Have a good day.